Thank you to the organizers of Cardio World Congress. I'm very delighted to have the opportunity to present results from the MIRABELLA HIV study. Several large cohort studies have consistently shown that the rate of myocardial infarction or coronary heart disease is 1.5 to 2-fold greater in well-treated persons with HIV or PWH compared to those without HIV. Data from our Mass General Brigham database from Triant and Grinspoon, highlighted here on the left, further demonstrate that this increased risk is not solely accounted for by the typical risk factors associated with cardiovascular disease, or CVD, such as age, sex, and dyslipidemia. Rather, the risk of heart disease remains high even after controlling for these traditional risk factors. Further exploration of potential non-traditional risk factors implicated in CVD and HIV therefore deserves serious attention. We do know that chronic, systemic, and local inflammation persists among persons well treated with HIV who are taking antiretroviral therapies. And this chronic inflammation, in fact, may drive the increased burden of heart disease. Using coronary CTA, our group has demonstrated that persons with HIV without known CVD have increased atherosclerotic plaque and markers of immune activation, including CD163, as shown here on the left. And this is when compared to well-matched persons without HIV. This plaque tends to be inflamed and non-calcified, as shown here on the right, and vulnerable, all characteristics that make coronary plaque more prone to rupture. We have additionally shown that in the absence of intervention, about 80% of persons with HIV have subclinical progression of plaque over a year. Shown here on the bottom right is an example of a participant who had increased plaque progression without intervention, and this really highlights the natural history of disease. FDG PET can be used to identify arterial inflammation. Uptake of FDG in the vascular wall reflects an area of highly inflamed endothelium, dense with macrophages, which is prone to plaque development. The target to background ratio, or TBR, measures arterial FDG uptake. TBR is calculated by dividing the mean arterial standardized uptake value, or SUV, by the mean venous SUV, as shown here on the upper right. TBR is well known to correlate with histologic markers of inflammation and is a very reproducible method. On the bottom right here, we can see in a study by Van der Valk that FDG uptake metrics were significantly different between healthy individuals and those individuals at risk for heart disease or with known CVD in both the carotids and aorta. And therefore, this technique may help discern disease groups. Using FDG PET to measure arterial inflammation, we have previously shown that well-treated persons with HIV on antiretroviral therapies, or ART, without clinically evident CVD have increased arterial inflammation compared to persons without HIV, who are matched for traditional CVD risk factors such as age and Framingham risk score. In the top right figure, you can see an example of an individual with HIV demonstrating increased FDG uptake in the aorta in both the coronal and axial views. Shown here on the bottom right, a TBR greater than 1.7, demarcated by the yellow line here, is associated with increased mortality. You can see that persons with HIV have elevated TBR above the threshold for increased risk of CVD events. And moreover, persons with HIV have similar TBR to those persons with known and evident cardiovascular disease. Now, keeping in mind, this HIV group is well treated on antiretroviral therapies with low viremia and is asymptomatic with respect to cardiovascular disease. So it is quite interesting that they seem to have increased arterial inflammation comparable to those with known CVD. Few prior strategies have investigated arterial inflammation, HIV, newly initiated ART in treatment-naive persons with HIV had discordant effects to restore immune function without reducing arterial inflammation. Thus, we know that complementary therapeutics to antiretrovirals are really needed to reduce arterial inflammation in HIV. In an open-label study of canakinumab, an interleukin-1 beta inhibitor in persons with HIV, this study demonstrated a 10% decrease in arterial inflammation. However, this study was conducted without a placebo comparator. In an RCT, there was no significant effect of atorvastatin on inflammation of the aorta as measured by FDG PET among persons with HIV compared to placebo. However, statin therapy did show other benefits. There was a reduction in non-calcified plaque volume and high-risk coronary plaque features. Based on these studies, further investigations are needed, and we are still very much in need of a potential therapeutic strategy to effectively reduce arterial inflammation. The renin-angiotensin-aldosterone system, or RAS, is a key hormonal system important to maintaining cardiovascular homeostasis. We have previously shown unique RAS physiology such that persons with HIV have increased RAS activation, which is associated with visceral adiposity, insulin resistance, inflammation, and altered natriuretic peptides, all relevant CVD risk factors in HIV. And complementary to this, we have shown that RAS blockade using mineralocorticoid receptor antagonist, eplerenone, improves intramyocellular lipid and metabolic and inflammatory indices in HIV. With regards to arterial inflammation, we have previously shown increased RAS activation among persons with HIV in association with an increased marker of arterial inflammation, lipoprotein-associated phospholipase A2, or LPPLA2. LPPLA2 is a vascular-specific biomarker of inflammation, which is produced by macrophages, participates in LDL oxidation, and has a critical role in the pathogenesis of atherosclerotic lesions. Shown here on the right, LPPLA2 levels were significantly higher among persons with HIV versus persons without HIV during the RAS-activated state, which is simulated using a very low sodium diet. This suggests a plausible biologic link between increased aldosterone and arterial inflammation in this population, and therefore RAS activation may be a potential novel targeted strategy for CVD prevention in HIV. Given our prior data, we hypothesized that excess RAS activation is a pathologic mediator of arterial inflammation among persons with HIV and sought to investigate a RAS-based physiologic strategy through mineralocorticoid receptor antagonism to reduce arterial inflammation in HIV. MIRABELLA HIV was a 12-month double-blinded placebo-controlled trial, which was conducted as a sub-study of the main study, the Miracle HIV study. 40 persons with HIV were randomized 1-to-1 to receive eplerenone 50 milligrams twice daily versus identical placebo. Those enrolled in the main study were invited to participate in the MIRABELLA HIV sub-study if they were not receiving a statin medication. Of these participants, 26 participated in the MIRABELLA HIV study. Participants underwent cardiac FDG PET at baseline and 12 months. The primary endpoint was change in index vessel. Arterial FDG uptake was evaluated in 3 target arterial locations, the aorta and the right and left carotids. Of these 3 arteries, the artery with the highest FDG uptake at baseline was identified as the index vessel. The secondary endpoint was TBR of the most diseased segment, or MDS, of the index vessel. The MDS was defined as the arterial segment centered on the slice of artery demonstrating the highest FDG uptake at baseline and calculated as a mean of the maximum TBR values derived from 3 contiguous axial segments. Overall, 23 participants completed the MIRABELLA HIV study. All inclusion-exclusion criteria for the main and sub-study were similar. We enrolled persons with HIV between 40 and 65 years of age who were well controlled on stable ART and had a low level of viremia. Major exclusion criteria listed here and included those with known CVD, uncontrolled diabetes or hypertension, and severe kidney or liver disease. Other medications acting along the RAS pathway, such as ACEs and ARBs, were not allowed. As previously mentioned, those with current statin use were excluded to understand the effects of eplerenone alone on arterial inflammation. Baseline demographics and clinical characteristics are shown here among treatment groups. Treatment groups were of similar age and sex. The majority of participants were male. Overall ASCVD risk was low to moderate. There was similar and low proportions of hypertension between groups. In addition, glycemic and lipid measures in both treatment groups did not differ and were generally well controlled. Participants in both treatment groups demonstrated a chronic history of HIV infection with mean duration of 17 to 18 years and were well treated on ART with good immunologic control as measured by the CD4 count. TBR levels were similar and elevated at baseline in both treatment groups. To get an idea of the levels of disease when combining groups, baseline median TBR was 2.59 for the index vessel and 2.72 for the MDS of the index vessel. With regards to the primary endpoint, TBR of the index vessel decreased significantly with the eplerenone by 12.4%, while TBR in contrast increased by 5.1% with placebo. Furthermore, there was a significant effect of eplerenone to decrease TBR of the MDS of the index vessel by 19.1%, while TBR alternatively increased by 6.8% with placebo. This was the secondary endpoint. Again, the MDS reflects the segment of the vessel with the greatest inflammation and therefore may reflect an area susceptible to treatment effect, consistent with our findings here. The figures below illustrate these percent changes by treatment group. You can see very little overlap between groups. Similar results were seen in supplemental analyses after controlling for 1 ASCVD risk score, as well as 2 current tobacco use and 3 changes in systolic blood pressure, the latter of 2 which is not shown here. In additional analyses, we explored the carotid vessels alone. In a similar pattern, TBR of the index carotid vessel was significantly reduced with eplerenone by 10%, and in contrast, increased by 9.7% with placebo. When taking the average TBR of the right and left carotid arteries, TBR again was significantly reduced with eplerenone by 6.6%, while TBR alternatively increased 6.2% with placebo. Importantly, summarizing the primary data and these data shown here, we see consistent effects of eplerenone to reduce arterial inflammation in the most diseased vessel, the most diseased segment, and also by vessel average, which really supports our findings. We were able to leverage cardiac MRI imaging, which was performed at baseline and 12 months as part of the main Miracle HIV study. We saw that reductions in arterial inflammation in the MDS were related to improvements in myocardial perfusion as measured by stress myocardial blood flow on cardiac MRI. Emerging evidence suggests that microvascular dysfunction may precede obstructive atherosclerotic disease and may be linked to inflammation in chronic diseases. We now show here that reductions in arterial inflammation are associated with changes in microvascular flow when treatment with eplerenone is applied. We also confirmed the actions of eplerenone. Those randomized to eplerenone had a significant rise in urine aldosterone after 12 months of treatment. This is consistent with eplerenone's known mechanism of action, blocking aldosterone at the receptor, and may be a surrogate measure to suggest good study drug adherence. There might have also been a trend of eplerenone to decrease blood pressure. With regards to safety, the medication was generally well tolerated and no dose reductions were required. Importantly, there was no medication-related hyperkalemia or hypotension. There was more dizziness reported with eplerenone use, which is a recognized potential side effect, and in general, study withdrawals were not due to adverse events. So in conclusion, despite no history of CVD, we see those with well-treated HIV and low levels of viremia demonstrate increased FDG uptake at baseline, consistent with prior data. We have shown RAS activation in association with LPPLA2, a key marker of arterial inflammation among persons with HIV. And now in the MIRABELLA HIV study, we applied eplerenone as RAS blockade, and eplerenone was shown to significantly reduce arterial inflammation among well-treated persons with HIV without known cardiovascular disease. In addition, a greater reduction was seen in the most diseased segment of the index vessel. We also showed that reductions in arterial inflammation related to improvements in myocardial perfusion. These initial studies suggest eplerenone may be a clinically useful medication to prevent the development of inflammatory-mediated cardiovascular disease among persons with HIV. Future studies are needed to test this more rigorously and to further understand whether eplerenone can improve CVD outcomes in HIV. With that, I would like to acknowledge the study participants and my colleagues for all their contributions to the MIRABELLA HIV study. Thank you.